Hi, Varun sir.
Really, Rahul. Sorry, go on. I'm just checking someone. Okay.
Yeah.
All right. Go ahead. I
Solid.
asked Amar to join. I don't know whether Amar is there here.
Okay.
Do you remember Amar? I said you
Yeah,
about
yeah,
Amar.
yeah,
Yeah.
yeah.
So he will be joining us soon.
Okay.
I'll just wait for someone else. If anyone else is interested, then we can. People are waiting, but the thing is, it's an odd time for the thing. Sakib is also here. Sakib, its time was 8 o'clock. Is bit odd time from you. If it is 8 in UK, then it is something different in different area, isn't it?
Yeah.
Guhan, what I have done is I have made the slide for a
Yeah.
transplant for a liver failure thing.
Okay.
I'll just check. I'll just add this thing to the screen share. Just a second. I'll share the screen. Check if it is possible. Then we can. Shall we start?
Sure.
Oh, Amar? I think Amar has gone. Has come in. Amar? Amar is in.
Can you hear me, sir? Hello, can you hear me?
Amar, I'm here. I'm here.
Hi, sir. Hi.
Good
Hello.
evening. Thanks, Amar. Thanks for
No
coming.
worries.
Thanks for joining.
Hi. Hi, Guhan. Hi.
Hi. Hi.
Amar,
How are
First
you?
time I'm
Guhan,
meeting Guhan. Hi.
first time you're seeing Guhan.
Yeah.
Amar,
Hi.
Guhan is appearing for the exam in next few days.
Sure. All the best.
Yeah.
Thank you very much. Thank you.
So, Amar, this is purely an hepatobiliary
Okay.
HPB, and this is going to. I just wanted for this for Guhan
No
for the
worries.
sake of Guhan, and there are few things only targeting few exam goers, and also it will be a revision for everyone, isn't it?
Okay. No
It's
worries.
not only. Shall we start, Guhan?
Yeah, sure.
Just a second. Oh, am I? Okay, Guhan. Amar, just observe. I'm going to give him a 20 minutes time. It will be like a 20 minutes time, and then after 20 minutes, you can ask him any questions or whatever. If you think that you can add few points, and you can say about the goods and good things and the bad things. Okay.
Sure. This is like long case, is it?
This is a long case, 20 minutes.
Okay. That's
Okay. Guhan, shall we start?
Sure. Sure.
Okay. Guhan, you are a consultant in the epidemiology unit, and you get a call from the DGH from a consultant saying that ITU consultant saying that there is a 25-year-old female who has been referred in there by their medical team with a paracetamol overdose, and she committed some suicidal intake of like 50 tablets of paracetamol of 500 milligram, and she is in ITU with an acute liver failure. So
Yeah.
how are you going to talk to this consultant? What are the things which you want? How are you going to approach this patient?
Yeah. First, just a meeting. Yeah. So this is a 25-year-old lady, and I would be asking the consultant, the ITU consultant, about more about her, and I would be asking, as you told, she had taken the tablets in a suicidal intention. So I would ask when she had taken this tablets, and how long has she been at the hospital, and how has her progression been in the hospital, and she's in the ITU now. What is her A, B, C, D, and how's her vitals, and how's her liver function currently? How's her INR? How's her mentation? Is she
Okay,
in
she
entering the
to come in with, she was initially in A&E for 3 hours, and her intake was like around 20 hours back, and she came into A&E 20 hours after her intake of paracetamol, and she was in A&E for 3 hours, and the ITU and the A&E consultant wanted to refer her to ITU, and she was a bit drowsy, and they thought that she needs more support in terms of her airway and her cardiac support. So what are the things you'll ask more about in terms of history in the A&E?
Yeah. Yeah, in terms of history, I would be asking about her, the intention of her taking her
she
tablet more.
she was depressed with her lifestyle, and she is not able to cope up with the lifestyle, so that's why she tried to commit her suicide.
Okay, and I would get a more detailed, like about the 50 tablets, whether it was about the total dosage, and whether
She
she is
was
vomiting out.
her boyfriend was there next to her, and
Yeah.
the boyfriend said that he noticed the open bottle, and she took 50 tablets. Probably the whole bottle was empty, and she was feeling drowsy. She was lying down on next to the bottle.
Okay. Okay. Yeah, these are the main. So you told me that she had become drowsy after she came to the A&E,
Mm.
and maybe I would like to know about the progression. Like, is she like progressively becoming drowsy?
Yeah,
And
progressively drowsy, and
yeah,
that is the reason she was intubated, and
yeah,
she was transferred to ITU.
yeah. So I would talk to the IT consultant about her vitals currently. Is she on BP supports, and has she started? This lady has acute liver failure. The things I would like to know is about her vitals, whether she's on BP supports, and how's her urine output, how's her liver
She
function.
was she was intubated, and she is on NG tube.
Yeah.
Her vitals, her heart rate is 112, BP is around 60/50, and uh, uh, she's on inotropic support, not to the maximum. She's on inotropic support.
Yeah. And whether they have started the ALF, acute liver failure management, whether they have started N-acetylcysteine, and
Yeah, N-acetylcysteine was given in the A&E itself.
yeah. So probably I think she would be receiving infusion of N-acetylcysteine by now. And again, I would like to know about her liver function test, about ABG, and is she having
Her
acidosis?
liver function rate, her bilirubin is 120, her ALT is 400, ALP is 200, and her GGT is 425.
And her INR and lactate as well.
INR is 4.5, and lactate is 3. After the resuscitation, when she came in, it was 7.
Yeah, yeah. So clearly, this lady is having acute liver failure, And one concerning thing is her BP, despite the vasopressor, it is quite low. So, and how, what about her urine output?
Her urine output is initially to when she came in, it was like 10 mils per hour. When she is now, it has improved to 60 mils per hour.
Yeah. So, this lady needs a management in a specialist unit. So, I would organize for an urgent transfer once to
Yeah,
a
the
specialist unit.
consultant rang you just for the transfer purpose. So he
Yeah.
wanted to transfer this patient to liver unit, and also asks you about the further management in terms of any transplant, or what could he do from his end.
So from his end, he has to optimize the patient for the transfer because since she's hypotensive, there is a possibility that during the transfer she might have a sudden collapse. So before the transfer, I would like him to optimize the patient in
So
terms of.
how what are the uh, optimization methods
So,
you want to advise him?
so in acute liver failure, especially with encephalopathy, I would like him to start on vasopressors
So
to
the patient is already on vasopressors,
uh,
on dobutamine or whatever inotropics, as the ITU consultant says.
yeah, appropriate vasopressors with a mean arterial pressure of at least like 65, I would like. And in order to prevent uh, uh, intracerebral hypertension, I would ask him to start on mannitol because these patients may get a sudden cerebral edema
Okay.
causing uh, coning, and and this could preclude any further treatment options for them. So ideally, I would like to start on mannitol to reduce the cerebral edema as well, and I would ask him to transfer the patient, and further workup would be with us.
Okay. So you accepted the patient, they stabilized the patient, and you accepted the patient. So how are you going to proceed in the liver unit?
So first, I would see if she satisfies the transplant criteria. So that's the King's College criteria, mainly based on INR, liver enzymes, and paracetamol or non-paracetamol poisoning. These are the parameters that, and her encephalopathy level as well. These are the main things that come under King's College criteria. So I would score her whether she satisfies the King's College criteria. In this case, I think she would be a candidate for an urgent transplant. So she needs a workup for her liver transplant. So I would get a CT of again do her first. Once I receive her, she would move to the ITU, liver critical care unit, and again
So this patient has been transferred from ITU to ITU. So the patient is already in ITU, liver unit ITU, and this patient satisfies the criteria for urgent liver transplant. And how are you going to talk to the how are you going to organize your team of doctors are happy to proceed with the transplant, and one of the relative is happy to give some is happy to be a donor. So how are you going to proceed now?
yeah. So, so it is good that one of the relatives has come forward to donate liver as well. So, but before considering that, I would like to first evaluate her whether she's fit for a transplant currently. So. She would have to undergo a pre-transplant workup. This is an urgent one, so she would need all the workup from cardiac, respiratory, her blood investigations.
So she's a fit and healthy lady, so she doesn't have any previous comorbids. She's a fit and healthy lady, no comorbids. Everything is set, and she's a fit candidate for
I,
transplant.
I would organize for a CT head and CT abdomen as well. And main things I would see is whether she has got any signs of higher function damage, such as coning due to the cerebral edema. That's the main thing that I would like to rule out from the CT head.
CT head is normal. Things are normal.
Yeah,
CT
and
abdomen
a
is
neurological
shows.
examination as well. And okay, and then if the CT abdomen, I would see for the arterial anatomy, the portal venous anatomy, and is the liver necrotic, and all these things I would see. And and ideally, this patient needs a transplant as early as possible. So this is a multi-team approach,
Do
and
you want to do anything for the donor, please?
yes. So again, this is a since it's a multidisciplinary approach. So there has to be an urgent meeting between the hepatologist, transplant surgeons, ITU, and everybody. And so the question here is whether this patient goes on a super urgent donor list, seeing her blood group, super urgent cadaver donor, or we go for
No, the relative is happy to. Her mother is happy to donate the liver.
yeah. So in that case, I would work up her mother. So first thing I would see is her blood group. If it matches, then I would go for all the routine blood tests, including a liver function test, and see.
Mother is also a fit and healthy lady. She is a 50-year-old fit and healthy lady, no comorbids, not an alcoholic, not a smoker. Blood test normal. She doesn't have any issues at all from the terms of mother.
I would do a CT abdomen to see any anatomical abnormalities precluding.
CT abdomen is normal.
Yeah, in that case, I would talk to the family, counsel the family about what is going on and what we are planning to. So I would like
any
to tell
any specific test you want to add up in the donors.
The donors actually has to
investigation blood test.
Has to donor blood test mainly. It's the INR, liver function test, complete blood count, and blood grouping and typing, and any antibodies, hepatitis virus, viral markers, HIV, and then any viral etiology like CMV or toxoplasma. These are the main things that I would like to.
Okay, so everything is set, and your team of doctors has done the transplant, and post-operatively this patient is in the liver ITU, post-op liver ITU, and first day like almost all the liver functions has come down to 50%, or like 80% liver function has regained back, and second day, third day she was fine, and fourth day she has a sudden raise in her bilirubin.
Yeah. So, so is this a living donor transplant?
Yeah, living donor transplant. The mother donated. Yeah. Everything. Everything happened, went well, perfectly fine transplant. Yeah. Third day, up to third day, mother recovered well. Mother is well, and the daughter is in the ITU. On regular bilirubin, there is a sudden increase in bilirubin on fourth day.
So if there's a sudden increase in bilirubin on the fourth day, I would like to assess her clinically, how she is, whether she's extubated, how's her liver function, how's her lactate level, is it on a downward trend? Is
the lactate level is again, it is creeping up to 7.
Okay. I would review her drains if she's having any bleeding.
Drains are okay.
And I would see her blood tests. If only her bilirubin is going up, or her enzymes is all.
Her enzymes are also raising. Her ALP is 400, and ALT is it's 350.
Yeah. So the bilirubin almost like rising. The main cause things that I would think here is whether she's got acute arterial or portal venous problem.
So yeah,
so I'll
what
get urgent
investigation
Doppler.
You want to do for that?
Do an urgent Doppler to assess.
So urgent Doppler says that there is a clot in the anastomotic site of the hepatic artery anastomotic site?
So if there's a clot, then I would like to see if it's a partial clot or a complete block.
It's a complete occlusion.
In a complete occlusion, it's an emergency. So two things. One, I would like to go in urgently and remove the clot and reperfuse the liver. And the second thing is I would super urgently list the patient for a retransplant if this strategy doesn't work out.
Okay, so you went in and you removed the clot, and then the patient, you re-anastomose, the patient is fine next day, and the mother asks, is the liver viable, because she is much concerned now whether the liver will be okay or not, because she has lost a liver and the daughter has gained a liver. So she wants to know what is the future of the liver in this scenario.
So in this case, since there's an acute arterial thrombus that we have removed the thrombus, so ideally patient needs to be on aspirin and she's high risk arterial protocol. So aspirin and anticoagulation as well has to be aid appropriate. And
so what prophylactic immunosuppressant are you going to keep this patient on?
So this patient will be on dual immunosuppression. So it will be initially we start with 3 immunosuppression: tacrolimus, either mycophenolate, mofetil, or azathioprine, and methylprednisolone. So it will be 3 immunosuppression in at least for the first 2 months. Gradually we taper off the steroid, and over the next year or so we taper off the mycophenolate or the azathioprine. And finally,
how are you going to monitor the tacrolimus levels?
So ideally in the immediate post-transplant period, the TAC level has to be somewhere between 6 and 10. So we monitor the tacrolimus levels before the daily morning TAC dose is given.
Do you want to do any other investigation with the tacrolimus level?
Usually,
okay. This patient is developing when you do the routine UNDs. This patient's creatinine level is high. So,
yeah.
what is it going to change your tacrolimus level?
Yes, exactly. So, if the renal parameters are high, then I'll reduce the tacrolimus dosage, since its main side effect is nephrotoxicity, and according to that, I'll maybe hike up on the other immunosuppression and reduce the dose of tacrolimus.
Okay. After 6 months, this patient develops diarrhea, and for some reason, this patient had loose stool. And do you want to add any specific investigation in terms of your immunosuppressants to check whether this patient has got any immunosuppressant related infection?
Main post-transplant immuno is the CMV. So CMV, there's a possibility of CMV colitis. So I would be checking for the CMV viral levels.
So what is the best investigation to proceed with that?
It's a PCR test of CMV DNA that's tested in the blood.
Will a colonoscopy be helpful for this patient instead of going for a PCR?
I'll do both PCR and colonoscopy as an adjunct to that.
All right. We'll stop here, Gagan. 20 minutes up.
Okay.
I'm not going to give any comments. Go ahead. Sorry.
It's going to be the end of your questions.
Okay. Amar? Is he here or has he gone?
Yeah, I'm here.
Oh, yeah.
So it was very nice, Gohan. You have a good flow of thought, and it is fine. That's what I could say. But I would suggest, just telling them off in the beginning what you're thinking of, especially with ALF and things like that. You're thinking in terms of ALF, sequelae of ALF, and probably need for a transplant. So if you could be upfront with that, I mean, instead of starting off the history with, you could say like, I'm thinking in terms of ALF and its sequelae and need for transplant. With that in mind, I'm going to ask this history and go 1 to 3. So the examiner knows that he knows what you're talking about.
Okay.
Otherwise, if you start on history, you're going to, you will start slowly, and and he might not know where you're going to. So at the starting, if you're going to start, you might as well, because basically you are at a level where you know, and the examiner knows what you need to know.
Okay.
So at the beginning, if you can just tell him that I'm looking at ALF and I'm looking at, so with that history in mind, I'll be looking at ALF and its sequelae and maybe a need for a transplant. With that, I'll be asking this history. If you can put it like that, that means that the examiner also knows what you're really, going to say. And it makes it so much easier for the examiner. The exam is basically to try to help the examiner understand that within that given amount of time, isn't it?
Okay.
It's as simple as that. So if you can aid him and tell him, give upfront a gist of what you're going to what you're thinking of, most likely you will end up on the right track.
Okay. Thank you.
And I think that's the only thing. But the other ones are minor ones, but those you're practicing, your flow of thought is very good. So I would suggest you would not have any problems. But that's the only thing. I think if you can just tell it upfront, it makes it easier for everyone.
Okay.
Amar, what about the N-acetylcysteine and all those things?
They will ask a normogram, but these are all very subjective. Some examiners will ask what normogram you use, the Rumac, what's that, Rumac-Matthew normogram, how much N-acetylcysteine you give, loading dose, this, that. But these are very subjective things. Some will ask, some won't ask. That depends on examiners and their interest also. But basically what the examiners are looking forward is a flow of thought, a flow of consistent, easy flow of thought. And that's what the examiners are looking. They're looking for a consultant who's becoming a consultant tomorrow. So as long as your flow of thought is good, and all these minor ones, like some of them may expect a nomogram. I don't know whether they would expect that. In India, they do expect that nomogram and things like that. The Rumac Matthew nomogram, I don't know whether they expect here. But these things are all just semantics. I don't think they really matter. But the other ones are fine. And if you could, all my thing is, if you could tell that in the front, that would be fine.
Okay, sure.
Amar, I've never worked in liver transplant, but I don't know whether my questions were appropriate or not. First of all, go ahead.
Very good.
No,
never been exposed to liver transplant.
It doesn't matter. I mean, you can just use it as you have to answer any type of question that they give in the exam. So it doesn't really matter what type of questions are being asked, as long as you answer appropriately, isn't it? So as long as, so in the exam also, you will have people who are asking different types of examiners who are asking different types. Of course, they will have a basic standard, but there will be lots of variations in the way examiners ask. So Varun is a type of an examiner. You can take it as a way of an examiner who's asking a different type of questions, but so you can answer, it's always good to answer these questions, but especially when you're looking at diarrhea, especially the 6 months diarrhea. So you can say with that history in mind, or you can say like with the history of 6 months diarrhea in mind, I'll be thinking in terms of opportunistic infections and toxicity, drug toxicity. These will be my two differentials. With that in mind, I'll be asking the following history, So the examiner knows at the start that this is what you're thinking of. He knows the parameters in which you are confining yourself to, which makes it far more easier for you to answer.
Yeah.
All right. I think that's very. Anything else you'd like to add, Varun?
No, Amar, this is just absolutely my my assumptions of questions. I don't have any idea, but this is my from my part 1 preparation, how to proceed with this scenario.
Sure. After this, maybe I could ask a couple of questions which really came for my exam. So sure. I could ask them.
No, you can. Yes, go ahead, please.
So no, it's not now. We'll finish it off. You have a flow of thought. Let it go. At the end of it, I'll ask. No worries. Just one scenario. I'll ask. Okay. That's so you can continue, Varun. You can continue. If anybody else wants to add something, they can add.
Do you want to, Saqib?
So hi, Saqib. So I think first, really, I mean, as Amar has already mentioned, it was a very good delivery, very fluent, very thorough, and the knowledge was right on the target. The only thing, maybe Amar can correct me if I'm wrong. The only thing that I was seeing in the presentation of Gohan was the management as per the presentation of a patient given in this scenario. He managed the patient like that. The patient has presented in an A&E right from there that I will see this in. Would it be a better approach that you think that these other things must have already been done, and you take this scenario from there, right? Because this patient was already in the ITU and the ITU consultant was giving you a call. So you start from there. Would I like to ask what is the A, B, C, D, how you're managing? Is he intubated? Is he sedated?
Even I felt the same thing. I
Yeah.
felt the same thing because
And the circulation, because the impression that I got that it was a management of a patient which Gohan is seeing the first time. How we can tackle this thing? Amar can can answer this question if he wants to.
There is no specific way. I would suggest if you are going to if the patient is an IT, you could say it's all a question of how you put it, isn't it? So it's a way you could say is, with the patient in ITU, I presume the patient would have already had the ABCE done. With that in mind, I would be asking this. So which gives the examiner the thing that you are aware that the patient is in ITU, that if he has come to the A&E, you would assume that these have been done. Because see, examiners are also of many types. Some of them would like you to start from the scratch. Some of them would like you to start from the, from where you leave. So there's no way of you knowing how each examiner is. So to cover all bases, I would suggest you just verbalizing it into thought. It would all require a few more extra sentences, like saying that I presume that the patient is in ITU, and then, but I assume that when he had come to A&E, this was done, and I expected that that his bloods were all sent. And then the examiner, if he's interested, he will go into it, and then you can leave it, because you never know, isn't it? Some examiners will want to go deep into it, some do not want to. And how would we know whether they would want to go deep into it or not? I hope this answers your question, if that's what you're asking.
Yeah. And from the Gohan, from your perspective, I just wanted to ask that the presentation was already given to you in an ITU. Why did you go for asking the managing it just like in the presentation in an ED and starting it from the scratch? What was your thought in that scenario? Although it was a very good demonstration, to be honest, but what was your...
Actually, I got a bit confused there, because he told, Varun sir had told, like, the patient was in A&E or for like 3 hours, and so I just got a bit off track there.
My first question is, the ITU consultant talks to you with the intention to transfer this patient to a liver unit, because usually the paracetamol poisoning is usually tackled at the DGH level. And if the ITU consultant thinks that this is not going to settle down, they wanted to transfer to liver unit, and he thinks in terms of transplant. That's the reason he wants to talk to you. There is a hepatologist usually available in any of the DGH or any of the NHS trust to give an opinion. But when they start discussing things with the liver unit, it means they want your opinion in terms of liver transplant. That is my thought process. If anyone has got any difference of opinion, I can...
No. I don't have any difference of opinion, and that was my thought, because that was my impression that in the DGI the patient must have been intubated, must have been sedated, relaxed, breathing must have been controlled, whether the inotropes are required, stress ulcer must have been prevented, antibiotic must be given, urine output must be monitored and managed well. So these were all, and even I was expecting a small MDT must have been done.
No, he mentioned about MDT. He mentioned,
but my assumption was that even at a DGH level, the anesthetist must have consulted with the gastroenterologist, hepatologist, and neurologist to the progress of the patient. So would it be better that if you take that information, extract that information from an ITU consultant, that what is the verdict of their MDT, and from the entire progress of the patient.
Yeah, as I was telling, it is, if the patient
It's
is
all
an ITU,
examiners.
you could always say that I presume that the patient would have come to A&E where this would have been done, and then if the examiner is more interested in those, you can go into it in detail. Otherwise, as I told you, no two examiners are alike, and you never know what the examiners really want. So I would suggest just touch bases and then go. It's like, say, I'll give you an easy example of a femoral hernia. A patient, a 78-year-old comes with a femoral hernia. How are you going to manage it?
Amar, I've got a scenario.
Okay, no worries. So if you have something like that, you would be in two minds. It's more or less similar. We'd be in two minds whether to start with A, B, C, D, E, or to go directly into the history aspect of it. So something like that. So where do you start? So just touch bases and then you can keep going.
All right. Anyone wants to join, they can unmute themselves, or you can put it in the group that they wanted to participate. I think Guhan can. If anyone do anyone wants to try? Do you want to practice? Saqib and me can do it next.
Sure.
Anyone in the audience wants to try? No. Okay. Saqib, do you want to do, or can I do?
Whatever suits you, no problem.
Do you have any scenarios? I've got the scenario.
Okay.
Just a short case. Just a short case. Yeah. Do you want to do it? This is a simple short case. I think you can do.
I'm happy to do that. No problem.
Yeah. Okay. Saqib, you are in a thyroid clinic. There is a patient who comes with a 45-year-old female who comes with a neck swelling. She was treated with thyroxine for the past 10 years for her hypothyroidism, and now she has been referred by the GP with pain in the pain in the neck for the past 3 weeks. So how are you going to approach this patient?
So, well, this patient from the history, it looks like that the patient had a swelling, a thyroid swelling, which is at the background of likely hypothyroidism, and that's the reason why she was taking. And I will be very worrying that she may not be having a Hashimoto's disease. However, I would be very concerned that this abrupt increase in swelling for the last 3 weeks is concerning. So I will take a detailed history of the symptoms, that how did this swelling increase in the size over the years. And more importantly, I would take the history of this pain as well, that since for how long this pain is. And did she has a similar kind of pain in the past as well. I would also take about the details of her thyroid history, more details of the thyroid history. When was she diagnosed with the hypothyroidism, and how much drugs she was using?
Okay, she was hypothyroid for the past 10 years. She is on 100 microgram of levothyroxine, and her pain is focused on the left side. And now she says that she has got back pain, and she has got polyuria and some bit of abdominal pain as well.
Okay. So in that scenario, I will take that the more details of this pain symptoms, and I will ask that whether the swelling has increased in the recent past or not. I would also take the systemic review history as well, in which the bony pain is more important, and then the any history of shortness of breath.
So it's a vague abdominal pain, vague back pain, and she has everything is vague. She is not able to clearly pinpoint the pain.
After completing this thorough history, I will do a detailed examination not only of the neck but also I would examine the lymph nodes as well. And in the examination, I will do the formal inspection both on the deglutition and without deglutition, and then I will palpate right from the back and the front as well.
So in the examination, you find some features of hypothyroidism, but however, there is a single nodule which you could feel on the right lobe of the thyroid, slightly posterior to the right lateral border of the thyroid, and it's a single nodule, and it moves with deglutition.
So any nodule, any
There is no lymph nodes and no other suspicious nodes or anything.
So any discrete nodule at the previous thyroid swelling will, with this background, I will be very worried for that, and I will let the patient know that this is a new onset, new change in your previous thyroid swelling, and if that happens, this might be something due to a sinister pathology, and for that I would request an ultrasound as well, and probably this patient will require an FNAC of that thyroid nodule as well, to rule out any malignancy in this new deposit.
So she has the as a consultant, you repeat the thyroid function test, including the thyroid antibodies and including the TSH receptor LATs, and also TPO, and all the thyroid antibodies. The ultrasound report says there is a small nodular swelling in the right lobe of the thyroid, posterior aspect, probably parathyroid. So how are you going to approach now?
So this parathyroid, if this swelling is likely from the parathyroid, and then it might be a parathyroid adenoma, which is causing the systemic manifestations in this patient. I would do this. I would complete my blood workup as well, which includes the thyroid profile, calcium, albumin level, corrected calcium level, and because this patient is symptomatic, this patient will be more benefited by the excision of parathyroid adenoma.
You want to add anything else apart from calcium?
Albumin, I said. Calcium, albumin, corrected calcium, PTH level.
Okay, PTH level.
Yeah, these are the levels. And before that, I would like to, if there is I would like to localize this adenoma by doing a Cystambi scan as well before an operation. And I would let the patient know that these systemic manifestation which you are having in terms of bony ache, polydipsia, polyuria might be abdominal pain is likely because
so this patient has a phosphate has a background history of chronic renal failure for some reason, with a phosphate of low phosphate. So what could you think of now?
So if the patient has a chronic renal failure, then I would take the history that how the chronic renal failure was managed. If the patient had a prior history of renal transplant or not.
So this patient's calcium is low, and her PTH is high. So what do you think of?
So if calcium is low and PTH is high, then it might be a secondary hyperparathyroidism, which is giving this. It is mostly at the background of a renal failure.
So provided we'll think in a different way. Now the calcium is high or normal, and the PTH is high. What will you think of?
PTH is high and calcium is
normal or slightly above the normal or high.
So if the calcium is normal, then
if the calcium is high and the PTH is high, okay, let it be like this.
So then there is a chances that the patient has a primary parathyroid adenoma, a primary hyperparathyroidism, secondary.
Do you want to discuss this patient in the MDT before you do a system scan?
So this patient will definitely require an MDT, but before that, I will complete my workup, which includes the blood workup, which includes the ultrasound, and which includes the Cystambi scan. And these are the workup that with which I will go to the MDT and will discuss how to manage this.
Okay, this patient has been discussed in MDT, and they say this is a parathyroid hyperplasia in a background of chronic renal failure.
So, although the findings do not match with that, because the previously ultrasound show the discrete nodule, I will be very concerned that how this patient has a parathyroid hyperplasia of all four organs. But I will communicate this information with the patient. And if that is the case, then most patients are not benefited with the excision of any dominant nodule or any dominant adenoma, but rather they required a 3.5 excision of a parathyroid gland, plus minus the transplantation of a
So this patient has got a PET CT. Consider this patient's PTH is high and calcium is high, and this is the CT PET scan or system maybe MIBI scan. So what do you see in this?
I can't see.
Do you see the image?
No.
You don't share. I think am I not sharing the image?
There is no. You cannot see.
I'm sorry. Oh, I'm sorry. I thought I'm sharing the screen. Just a second. Do you see it now?
Yes. So I can see that this is a PET CT scan of neck and the upper chest area axial view, which is showing some increased uptake on the left side in the neck region on the left side.
So what do you think now? What could be the reason now? Still, do you think that this is could be hyperplasia or adenoma?
So any increased uptake on the PET CT scan will be a suspicious for a adenoma/malignancy sequence, because this PET CT scan is very sensitive investigation for that.
So the patient is already again discussed in MDT, and they think that now it is adenoma. So how are you going to proceed?
So even if the PET CT scan is suggestive of an adenoma or a malignancy, I will not go for a biopsy in the cases of parathyroid. I will straight away book this patient for an open parathyroidectomy.
Okay. So tell me.
And I will rely on the histology on my main specimen, resection specimen.
Okay. During your ENT colleague is helping you. You removed the parathyroid, and how are you going to confirm that you have removed the parathyroid, not the fat?
Yeah, so I will check the parathyroid, because the parathyroid hormone has a half-life of 10 minutes, and I will check the serum parathyroid hormone at that time, and it should be half of the previously preoperative value.
Do you want to check for any other parathyroid, or do you just are you happy with this?
Yeah, I will rely with the parathyroid, and otherwise the other option is that you can localize it with an intraoperative ultrasound as well. But I think that is the most reliable. But there is a one criteria, Miami criteria as well, in which guides about the whether you have taken the.
All right, Saqib, I think I have to stop here. Your time 10 minutes. Guhan, Amar.
One thing I want to ask is, parathyroid, do we go for a stress maybe directly or a CT neck to guide, or?
If I'm Amar, correct me if I'm not wrong. Usually the MDT requests only ultrasound, and from the ultrasound they usually pick up the parathyroid, even parathyroid, and they do a CT scan, and rarely, I think after MDT discussion, they go for system EB scan.
I think now they have something called as concordant imaging, isn't it? So they do two imaging. So for a system EB scan, and they do a technetium a system EB scan along with an ultrasound. So they do it like a concordant imaging, isn't it, nowadays? That's what I was under the impression.
I was with one of the consultant. He said that they just do ultrasound and they don't do system EB at all. And if they do a parathyroidectomy and then they come back, if still they have the symptoms, they go ahead and do the system EB scan. If I'm not wrong, that's what I heard from the endocrine consultant.
I
no idea,
because this was what I was under the impression that they do both to localize by concordant imaging, like technician scan as well as a system EB scan as well as an ultrasound or concordant imaging, and if it shows both, you're reasonably sure, and then they go for a minimally invasive parathyroidectomy with a quick assay.
Okay. Overall opinion.
But so I just wanted to ask, what are the causes of primary hyperparathyroidism?
On parathyroid adenoma.
Yeah, that's the most common cause. What are the other causes like?
Parathyroid carcinoma.
No. I'm asking what are the causes of primary hyperparathyroidism?
I wanted to stress on men syndrome here.
But
that's the reason I brought both thyroid and the parathyroid together.
Oh, yeah. But no. The question I think which the Amar is asking, I think the causes could be adenoma, carcinoma, or
hyperplasia.
Parathyroid hyperplasia secondary to these men 2A, 2B.
I mean, that's fine. I just asked adenoma, hyperplasia, and carcinoma. That's it. That's what I was expecting. Nothing much. Sorry, continue, please. Carry on. Sorry, you're muted, Varun. You're muted, Varun.
Amar, your opinion. Sorry.
Sorry, I didn't hear what you're saying.
What is your opinion overall? From the history taking. Hello, am I audible?
Yeah.
If you're going to, sorry, Varun, if you're going to ask him about adenoma, you should like first fix what you're going to ask and then ask according to that. I think that will be better for him. Otherwise, he's also getting a little bit confused. That's what I found out.
Yeah, because previously I thought that this scenario is going towards a discrete node.
Yeah, he was getting a bit confused with the questions a little bit because initially you were going in more like a secondary hyperparathyroidism. Then it became like primary. So he was getting a little bit confused. And
okay.
That's what I was.
This is just for discussion.
I get it, but it's difficult, isn't it, for those who answer also.
To be honest, I would add, Amar, that I think that in the start, the impression that I was getting that this patient might have some thyroid swelling, and on that she has.
Yeah. So it was a bit confusing. So I initially it was like thyroid, then it was like secondary hyperparathyroid, then it became like primary hyperparathyroid.
But it has just
keeping things wide open. That's it.
It. So I think, Varun, I think that even I could self-assess myself, despite the fact that the history was going in a very different direction. But I think there are a lot of things that I, because I think that initially. I was finding a difficulty in whether to assess that this patient has a benign neck swelling or a malignant neck swelling. I wasn't unable to discrete that. When you gave me a sudden pain and sudden swelling, my impression was that, this patient has developed maybe a thyroid neoplastic lesion in a previous swelling. But I think here the history could have been much better. I think so. More importantly, we have already discussed many times that history followed by examination and investigations. I think the investigation part was very bad from my side, in which I think if I am given a next chance, I would say that I will do a full blood count, UNEs, liver function test, maybe thyroid test, parathyroid,
profile,
albumin, vitamin
bone
D
profile
level
is more important here, and
vitamin D level rather than jumping on an ultrasound and the FNA, because I thought I got an impression that this lady has developed an isolated discrete swelling in a thyroid that needs to be biopsy. And I was thinking that you will give me a result in terms of a thigh 3, thigh 2, and will be asking what's sort of next. But I think I did not stick to the basics, and the basics here were that I should have sent a proper blood workup before heading towards the examination, the part. And
from the history point of view, what I felt is like, is it okay to just say if there is any neck swelling, we can say we can check for symptoms of hypo and hypothyroidism, any symptoms of metastatic type thyroid cancer, any symptoms of parathyroid, any symptoms of oral cavity, nasal cavity, oropharynx, nasopharynx.
Yes.
So all pan endoscopy symptoms, just mentioning about the
If
symptoms.
you have a thyroid swelling, you're expected to say pain, you're expected to say swelling, you're expected to say pressure symptoms like like stridor, dysphagia, hoarseness of voice. You're expected to say you look for history of symptoms of hyper and hypoparathyroidism. So you have to mention all 5. So if you have
that's
a thyroid,
what I felt that like concise statement saying that I will get a focused history on pressure symptoms, hypo and hypothyroidism, hyper and hypoparathyroidism, any other swelling, any other secondary neck swelling because of endoluminal cancers like oropharynx, nasopharynx. That's it. Just 2, 3 or 4 statements. Otherwise, past history, is it okay to think of irradiation?
Agree. Past history of familial cancers, and in
a short case.
That's what I wanted. Can we ask Gohan? How would he do? Would have he done differently?
I think I was also not like very into the parathyroid thing, but one thing when he mentioned like abdominal pain and those things, you could have suddenly changed your differential diagnosis. I'm thinking both in as a thyroid as well as parathyroid. Just given a DD and then moved on.
Okay, this is just to bring up everything in 10 minutes, just to bring all thyroid, parathyroid, other neck swellings into one 10-minute slot. Nothing more than what I thought of.
It was very good, and I must appreciate. Thank you for. I mean, I had zero clue. I mean, I haven't read this topic yet, but yes, thank you for.
No, just to make things to come into. 1 10-minute, nothing more than what I want.
Brilliant. I must appreciate. It was a good drill. Thank you.
It was very good actually. The questions were good. And it was good for the thing also to answer. Yeah.
Okay. Anyone else from the audience can ask questions if they want to put it in the chat box. I can unmute all. If there is any need, they can unmute and ask questions, please. Ask all to unmute.
Varun, do you want to get a scenario, or I have a good scenario for you?
Yeah, I'm happy to do it. Just let's wait for the other people. If they want to discuss anything, I'm happy to discuss.
I didn't know you were discussing scenarios. I just thought I'm going to observe. So if it told me, I'd have asked some of my exam scenarios also.
Come on, you can ask. You can ask someone. Gohan is there.
Shall I ask one scenario? Yeah. This is just for 10 minutes. You keep the time. This was really asked for me in the exam, so
I'm just the moderator, Amar. I'm just moderator. If you tell me you are happy to ask him, then I can start the timings and I can moderate. No problem.
Sure, is it all right?
Sure.
So,
shall we start?
I didn't know. Okay, that's fine. You are a consultant. Actually, your registrar is doing surgery for a patient in theaters. It's actually a lipoma. It's a very simple case of a lipoma on the left hand. Okay, a 6 centimeter lipoma. He's operating. You are in the coffee room. Okay, then the nurse calls you, saying that instead of the left hand, they had put an incision on the right hand. Actually, he has multiple lipomas, right and left hands. You're planning to do a surgery on the left hand, but
Yeah.
unfortunately, your registrar has put an incision on the right hand.
Yeah.
Okay, and now he calls you to theater. What will you do? How will you manage this scenario? This is not my words. This has really been asked.
Yeah. So
This is too brilliant for me to ask also, so by myself. So
yes. So I would assess if so. I assume the patient is being done the surgery under local anesthesia.
unfortunately, they have done it under general anesthesia for reasons which we don't know, because the patient didn't cooperate for a local or something. He's intubated though, and he has had the he has had the surgery. They put an incision on the right side, for which it's a small lipoma actually on the right side. The left one is a larger one. It's like Derkham's disease, multiple lipomatosis.
Okay. And this incision on the right hand was over the lipomas.
Yes, but it was not planned for on the right side.
Okay. So if it was not planned on the right side, I would just I would scrub in and
You scrub in and do, yeah, you go to theaters. What will you do?
so I'll go to the theater and check the patient's consent and everything. I would talk to my registrar, like earlier, if I'd known about the patient. Anyway, I would like to confirm with him, like what are lesions have we consented him or to excise, and I would
It's
like
only
to know
consented
about,
for the left side lipoma only.
yeah,
Okay?
and I would like to know about the patient's symptoms and the number of swellings that he had on the left side, and what was a pre-op plan to excise which ones or
The
which one.
pre-op plan was just to excise the lipoma on the left. There was no plan to excise. So you've got a consent for excision of left-sided lipoma on the hand, on the arm, the large 6 centimeter lipoma. But your registrar has put the incision on the right side. Okay.
So I would check why this mistake happened, because whether a pre-op marking was done, pre-op WHO checklist was it done, and was all the protocol followed before the surgery. I would like to check.
Okay, the sign-in was not done properly, though it was even the marking was not done presumably. So what are you going to do? Because the patient is now intubated.
Yeah,
you've been called into theater. What are you going to say? How are you going to manage now?
So I think a mistake has happened that we have to acknowledge that. I already came to know that the checklist has not been for this thing, and marking has not been done. So this is like a negligence from part of the treating team that includes me. Since I'm the consultant for this patient. So I will scrub in and help with the registrar and excise the lipoma that we have consented. And the incision on the other side that he has made, I would close up and get the patient out of the theater. And later, I would, once he's comfortable, and make sure that he's pain-free, and then I would talk to him about the sequence of events, admit that a mistake has happened, and apologize. And
do you have any specific term for that we use in the NHS commonly? I mean, you would have seen it multiple times.
It is a duty of candor.
Yeah. So can you tell me something about duty of candor, please?
The duty of candor means that the treating team has to take responsibility for any mistakes, and the patient has to be communicated in a proper way about a mistake. And yeah.
Okay, so so after that, would you do anything else? So duty of candor, is it verbal or is it written?
I will do a proper incident reporting of this, because this mistake has happened at multiple levels. Starting from checklist and not marking the patient and everything. So I would do an incident report and so that there is a formal audit of this.
Yes. About this, who can do a duty of candor? Suppose you are not there, the consultant is not there. Can anyone else do the duty of candor?
I think the registrar can do, or the anesthetic consultant can do.
Anybody can do. So if anybody, so does that imply that that person is negligent? What does that imply? Suppose you do a duty of candor. Actually, this was done by a registrar, but if you do a duty of candor, what does that imply? Does that imply guilt on your, does it imply guilt, a duty of candor?
No, it's not guilt. So it is, since the patient is under my care, so I think it's the consultant's responsibility to talk to the patient about, even though if it's a registrar who has done this, but I think it's a consultant duty to explain the sequence of events to the patient. But I wouldn't say it's a guilt, because there are various mechanisms to prevent mishappenings in the hospital. If at all it happens, then instead of guilt, I will term this as a mistake.
It does not imply any criminal negligence on your part. Actually, a duty of candor, basically, a duty of candor takes into account three elements, basically, isn't it? Okay, we'll keep the feedback at the end. Sorry, I'm sorry. Okay. And what do you know about serious error framework reporting? Because that's what the other thing that they are looking for, serious error framework reporting.
All the errors should be reported as an incident report, and so that it is investigated by the appropriate team. Usually there is a lead in the department who is doing this. So any incident report that we are doing, so if it's a surgical incident report, it goes to the particular lead who is taking care of that, and he'll be investigating and submitting a formal report.
Okay, that's fine.
And any actions or changes that could be made could be counted as
All
well.
right. So I will stop with that. That's fine. So basically, they are looking at two aspects of it. What
Amar,
yeah.
Just before you give the feedback, just for the practice purpose, I think I and Saqib is also in the same boat. Like we are in the same boat like Goan, but Goan is just ahead of us. That's it. If you don't mind, we will give our input as well and make comment about all three if you're happy.
Sure.
Okay. The same scenario. I will start, Saqib. You can do it next.
Okay.
All right. The same scenario. If I was in the same position, I would like to come to theater, check the previous notes, check the clinic records, and make sure that which side has been accepted for the excision, and make sure that the mark consent has been mentioned in the consent, is the site has been marked properly, and site in the consent is written properly and also marked properly, and whether the WHO...
It's not marked, Varun, it's not marked properly.
Okay.
The consent is for the left side. Now you have come in, what will you do? What are your options?
No, that's what, make sure that whether the same side has been marked or not first.
It's not
check
marked.
For the marking.
It's not marked, I said.
Okay, it's not marked. So that is another issue. We have to, and then WHO checklist has been done or not, and was there it was not done properly, and the incision has been done. My doubt was whether to operate. I won't operate when the incision has been made. I just close it and come. And the next question is, are we going to operate the proper side which has been consented already? Should we operate on the consented side after incision has been made, and operate and remove the excision, and then make a formal incident report? Major incident report. I think this comes under major incident report. Incident in the theater, and make a DATEX And then once the patient is out of the anesthesia, when the patient is conscious, apologize first and saying that we made an incision on the wrong side, though it has been on the left side. We made an incision on the right side, though it is my registrar who has done it. As a team leader, I would like to apologize for the mistake which has happened, and then discuss things that we have removed the other side, but there is a skin incision or scar which has happened on the right side. And second thing is inform about the compliance procedure like pulse and all these things. If the patient wants to comply, make inquiry, formal inquiry, go ahead and do in pulse and escalate the compliance and mistakes which has happened. Then again, whatever the things like duty of conduct and all these things.
Excellent.
Sakib?
So yes, for the mistake scenario, I mean, I have just made one algorithm for myself. I mean, Amar can correct me. I think I would manage this scenario more or less in a similar fashion, but I would divide it into 4 more major components. One is the clinical management of the patient, because if mistake has happened, so has happened, and now we have to manage and we have to move on. So I think that we don't have any difference in this. That clinically, I think that this is the Gohan has presented the best way how it should be managed, that just close the incision and do the rest of an operation. Then the second scenario on the error part, I think that's the once the patient is awake up, then yes, duty of a candor is a very important thing, and that we have to fulfill. The third thing is that in my algorithm is the DETEX form, that incident reporting form, and you can fill this form. The fourth thing is that which I keep in my algorithm is to let the patient know that you have all right to formally complain, as Varun has told that in PALS he can go. And the fifth thing is that I would say that a formal feedback to the registrar through an educational lead or a supervisor. I think this is the fifth part which I will take into account in this sort of scenario.
Amar, your opinion on all 3?
Yeah. So basically, you can divide it into 2. One is an intra-op management and post-operative after he wakes up. Intra-operatively, considering the fact that it is not an emergency life-saving procedure, and the fact that it is a wrong side surgery, the best consensus-wise would be just to close the skin incision and wake him up and get this lipoma done some other time. That's one option. Or the second is to do the surgery and then wake him up. So there are 2 options, but I would prefer going for the first one because it's not a major surgery, life-threatening. It can be done again at some point of time, and the magnitude of our mistakes is high. So this would make me more in terms of going towards just closing the incision and waking the patient up, and then following up with the post-operatively doing 3. One is a duty of candor. So basically, a duty of candor they would expect is it tells us you 3 main things. What has happened to the, you have to tell 3 things to the patient. What has happened, how do we deal with it in the future, and how do we deal with things like this in the future, and how do we deal with it now. So all these things have to be explained to the patient. It can be given orally or it can be given written. It's up to you, but it's always better to give it in writing. And one more important thing is that it is done by the most appropriate person in the team. That is usually the consultant. So these are the things. It does not imply any criminal negligence or liability just because you are doing. So these are the things that they would expect in duty of candor 1. Second is I will do a serious error framework reporting, which is done in most trusts. They have this reporting. And the third is, as you said, to do an IR1 at DTX. And then a fourth is to have a chat with the registrar, whoever did this surgery, and also do a formal analysis of the thing. Especially with the serious error reporting, what they do in most trusts is it goes to the lead, they do a root cause analysis, and then they do a recommendations, which is a SMART recommendation. So basically a SMART recommendation is the report must be SMART, that is it must be specific, it must be measurable, then it must be actionable, I forgot the R. The T is time bound. So these are things that you take. It must.
So the smart is the mnemonics for that.
Is a mnemonic basically. The report is because you can't have a 20-page report, isn't it, for something like that? It must be very specific, measurable, achievable. Then I think it must be relevant. That's what is the R. I'm not sure. Relevant, and it must be time bound. So this is what they're expecting basically. So I don't know how you feel about this, but this is what they would I would do.
I think Gwen, this is actually a good. You won't get this thing. This is the best learning for you, I think.
One more thing I want to ask: what is the difference between a DATIX and a serious adverse effects reporting? Isn't
DATIX includes the inquiry. Yeah, incident form is something different.
So DATIX, I think there are a lot of things come under DATIX, you know, but serious error reporting is for serious errors. So serious errors have been defined as something that causes permanent harm, something that causes chronic pain more than 3 months, something that causes psychological harm, or something that causes permanent harm. So these, if you have all 4, it causes serious errors. So these go under the serious error framework, in which the lead has to analyze it, report it by smart reporting. The DATIX is for anything like mismanaged drugs. It doesn't necessarily need to be a serious error.
Okay.
It can even be, you know, giving an alter. We have it on the wards all the time. So they say they do, you know, DATIX for anything and everything now. So DATIX can be done for everything. Serious error reporting is precisely that. It is for serious errors alone.
Okay. Thank you.
All right.
Varun, you are muted.
Okay. Who wants to go? Can I go? Or?
Yeah, you can go if you don't mind. If you allow me to share the screen, then I can present you the scenario. Can I? Yeah, allow me to share the screen.
Oh, just a second. You want to share the screen, isn't it?
Yeah.
Are you okay?
Yes, I'm okay. Scenario 2. Let me see. No. Yes. Can you see the screen?
I'm scared of seeing this blood gas analysis, but I'm seeing the screen.
Are you all going for the exam in which they have no patience, isn't it, this time?
Sorry?
The exam has no patience, isn't it?
There's no patience, but in September, from September, I think there are patients.
Yeah.
You're going to get screwed soon.
Only for the long cases.
Really?
Are you sure?
Are you sure?
Yeah.
Varun, in this September, will they have a patience?
I don't know.
Okay.
I think I read somewhere in the RCS website, JCI.
I think I think it is more. I personally feel that patients are much more better than not having patience, because without patience, they can ask you anything and everything. All they need is a photograph. All they need is a photograph of some rare condition, and they can just take you anywhere. Whereas with a patient, you get a lot of time.
Like what I did for Sakib.
Yeah. I think patient is good. Patient is good.
Yeah. That's what I personally feel. I don't know.
Yeah.
Other people may have different views.
So, Varun, you have a scenario. You are a consultant on call. You get a call from ED consultant regarding a 74-year-old woman.
I don't see the picture. I don't see the slide. Just can you open it up? Scenario 2.
Yes, scenario 2.
Open it up.
You should be able to see.
Okay, go ahead. No problem. I'm just.
Let me see. Let me see. Why it's not opening? thought that. Mhm. Now, can you see now?
Yeah, okay. Yeah, go ahead.
So you're a consultant on call. This is a seven, and you've been run by an ED consultant saying that a 74-year-old man, known case of atrial fibrillation, diabetes, hypertension, now presented with a sudden onset of right leg pain for 4 hours. And these are the vitals. How would you proceed with this patient?
So on the way to the AAD, my thought process will be whether this patient has got an acute limb ischemia, which is, and I will think in terms of the history and the signs and symptoms relevant to it. And I look for, as it has been mentioned that there is a 4 hours history of pain. I would look into his previous history, whether he's a known vasculopath. He has got all previous comorbids like diabetes, hypertension, and he's an atrial fibrillation as well. With all these things in my mind, I'll get a focused history in terms of pain, site of pain, in terms of Socrates, site, onset, character, radiation, associated symptoms like any ulcer, any uh, uh, numbness, paralysis, pain, 6 P's. In terms of
So,
six
so, so,
P's,
so you read a 6 piece. The patient is complaining of pain, pillar. There is an increased and the limb feels cold to touch. Patient can sensate, but saying that the sensation is reduced, and he can move his toes.
so with this history, I would like to go ahead and check whether he has got any past medical history, his medication history, whether he
Patient
is
is
on.
known case of atrial fibrillation. He is on adixaban.
I would check whether he is continuously on Adaxaban, whether he has stopped his medication, and whether he has got any previous arterial or any surgeries related to his arteries, vascular surgeries. And I'll also check for any family history of any vascular pathologies.
So
Uh,
no family history of vascular pathology. Patient is a chronic smoker and smokes 20 cigarettes per day. All he knows that he had an ultrasound at abdomen, which shows an increased size of his aorta that was around 4.5 centimeter.
So, considering this in my mind, whether he is on regular follow up, I will check whether he is previous ultrasound, how far he's followed up for his aortic aneurysm. Has he been followed up with annual ultrasound for his aortic aneurysm? Check for any increase in size of the aortic aneurysm size aneurysm.
While you are doing that, patient is saying that his pain has got more worse. Doctor, please do something for me.
I'll get a quick examination, general examination, and focal examination of this both the lower limb, including the pulse. I'll check for his pallor. I'll check for his temperature first. How far the temperature is cold? Is it up to the knee or above the knee? And compare it with the opposite side. Check for his.
So you did an examination on the right side. Femoral pulse is palpable, but there is no distal pulse palpable on the right side. On the left, all pulses are all palpable. The right leg is feels too cold, and the patient has a numbness, but he's able to move his toes.
So in this scenario, I'll think of embolic phenomena because of his previous atrial fibrillation. However, he is on rivaroxaban, he is on coagulation. The left side is palpable. So I will discuss with the vascular consultant, check with the vascular consultant, what should we do better. The option will be to heparinize as early as possible with 80 international units per kilogram body weight. Paradise. That would be the suggestion from the vascular probably. But anyhow, I'll discuss with the vascular consultant as early as possible for a transfer. And if possible, if he thinks that he needs a CT angiogram, I'll request a CT angiogram before all these things. As this patient is in A&E, I would like to do all blood investigations, including lactate, CRP, D-dimer, and rest of the bloods like UNEs, LFTs, bone profiles, and etc.
Okay, so you somehow you had this scan in front of you. What is your interpretation?
So this is a CT angiogram of the lower limb, which is showing that there is an abrupt cutoff at the distal level of the popliteal artery. With there is a distal runoff in the tibial artery, probably some kind of collateral. Is it right or left? Yeah, it's right. And yeah, there is some kind of distal runoff. There's a distal cutoff at the popliteal artery.
Okay, somehow you plan with your you plan with your vascular surgeon. You have a vascular surgeon here in your hospital as well, and he wants that you to shift this patient and we can do and planning to do a surgery. Can you tell me what is the approach you can take in doing a femoral embolectomy?
If it is a femoral embolectomy, I would like the approach will be I have not done it, and the approach will be catheter.
Yeah, vascular surgeon is on the way. He's saying that you are a surgeon on call. Just take this patient. I'm on the way, and we can manage it together. Till take care of the patient till I'm on the way. And can you make a start of that embolectomy?
I have not done it, so I will wait for him, and if I'll ask him what incision I will make, but the incision will be lower to the inguinal region, medially and vertically along the femoral artery, probably, and open the skin, subcutaneous tissue, open the fascia, retract the sartorius, and get into the femoral triangle. Lateral to the femoral vein. I'll expose and I'll keep. I will wait for the vascular surgeon to come and open up the artery.
Are you aware of the steps of embolectomy?
I'm not aware of the steps of embolectomy.
Okay. Is there any other way is there any other option if the patient is not a candidate for an operative intervention?
Catheter-directed thrombolysis is an option. That will be I'll discuss with the radiologist and the vascular surgeon.
Are you aware of any classification system of acute limb ischemia?
Rutherford classification.
Okay, according to the Rutherford classification, where this patient falls?
This patient will come under first, I think, type 1. I think is acute limb ischemia. I'm not sure about it, but I think so. I forgot the classification.
Okay. Is there any role of any Doppler on the bedside?
Bedside handheld Doppler can help, but when there's a patient with classical feature of acute limb ischemia with a pale, cold limb and no pulsation.
While revascularization, what is the immediate complication that will be you'll be very worried for?
Post embolectomy distal showering of the thrombus and post skin necrosis and the
after a successful revascularization, what will be the complication which will be you worried for? You have done
reperfusion injury. I will be much worried about reperfusion injury, looking into electrolytes like magnesium and potassium and magnesium.
Is there any role of fasciotomies in such patient?
If the patient exceeds 6 hours time limit, and if there is if we think of this patient can go for a compartment or reperfusion injury, then we can plan for a fasciotomy. It's up to the surgeon's discretion. It depends on the surgeon.
Good. Thank you, Varun.
So, I'm absolutely, I hate vascular. Somehow I try to manage it.
Yeah. So go on, feedback.
You did well. You did well. Feedback wise, I'm not able.
Or how would you have done differently this scenario?
I think I would have done the same. I don't think anything else I could add upon this.
Amar?
Yeah, it was fine actually. The scenario was fine. But if I think it's all a question of verbalizing, isn't it? So if they ask you how will you manage the patient with acute limb ischemia, you could just say that the management is like threefold or fourfold or how many fold. Like one is medical, in which I will give him oxygen, fluids, IV heparin, analgesia. The second is surgical, where I would plan for a embolectomy. The third one would be thrombolysis if the patient is not surgically fit, and if the limb is non-viable, for an amputation. So something like that, which shows that you have overall you have explained the options.
Okay, so
That's the only thing
we
that
can
I
make
could say.
it as a like a package rather than just pertaining to this scenario.
Yeah, that's what I'm saying. Initially, if you give I think a synopsis of what you're going to say, and then you can go into detail, because sometimes we get caught in those small, like an incision. You get stuck in an incision, and after some time, it's very difficult to extricate yourself and come back to the overall picture. So this is just an exam technique, which I would prefer, in the sense, give an overall bird's eye view of what are the treatment options available. Then but all of this is based on the writer that the examiner is listening. Sometimes the examiners are like, they will want you to go directly to embolectomy, in which case you don't have a choice. But what I would suggest is, you give an overall picture, bird's eye view, and then go to just a couple of words or sentences would be enough. Just to give an overall view that these are the options available, and then you can go on to
so
it.
what about the history and examination?
Yeah, history was fine. I mean, history was fine. I would say examination also, you mentioned everything, vitals, you mentioned abdomen exam, vascular exam, motor exam, sensory exam. Did you mention motor and sensory exam?
I said about 6 P's. In that it comes to
that's history, isn't it? That's
no,
history.
neurological examination was missing. Yeah,
that's what motor and sensory exam.
Yeah.
So you should have general exam.
Not only for the same limb, but also the contralateral limb as well. So that's very important.
Okay.
So our supplementary question.
And fasciotomies, as I say, sorry, before I finish, I think fasciotomies is a must, because most of them do a fasciotomies. As far as I've seen, I don't know now, but what I've seen is that they do a fasciotomy. Sometimes they do fasciotomy when before even doing the embolectomy, because the thing is that if it is really, if they find it unviable, they don't do a embolectomy. But even then, after an embolectomy, they do a fasciotomy. A prophylactic fasciotomy is always done, isn't it?
This patient, Amar, what I thought of was like, this patient is 4 hours duration. I don't know. I remember somewhere I read if the fasciotomy will be helpful.
FRCS companion. I can tell you the reference. FRCS companion pool.
I don't know. I don't remember now.
Yeah, I don't know from where he has got that 6 hours, but yes, it was written that.
Yeah, I read that too. Yeah.
Okay, so is it like a prophylactic fasciotomy always recommended, or is it surgeon's option?
Usually it is surgeon's options, but they do, isn't it? That's what I've they do a fasciotomy after prophylactically. Mostly they do. So I mean, I would not err on this. I would rather err on the side of a fasciotomy. Just an exam, so you might as well err on the side of
reperfusion. While he was asking, you didn't like go back on the reperfusion. You were telling about magnesium and all those things.
Oh, I'm sorry. I completely forgot about reperfusion injury. So I was trying to remember things about reperfusion.
And I think what he was thinking about, the incision was a femoral artery, which is the midinguinal point, isn't it? So
is it right actually? First thing is it right?
Yeah. You go for a vertical.
Vertical axial incision over the midinguinal point, so that you get onto the femoral arteries.
Yeah.
So that is right. Okay, thank you. Because I was just assuming that I'm going to expose the femoral artery. So I thought that could be the incision just below the inguinal ligament, palpate the femoral artery, just medial to the femoral vein, make an incision. That's it.
But my question is that when you have a vascular surgeon available, is it good approach to throw everything to him, or if the examiner is asking and then you're showing your knowledge that I know where to place an incision and what are the steps, or it's just simple to just put everything on the shoulders of the vascular surgeon.
See, it is an exam, so they're expecting you to answer. What is they're not, it is an exam, you see, they're expecting you to say something on that topic. So I would suggest you can just say, I would consult the vascular surgeon, but as in every question, the main thing is they want to see what you know.
Okay.
Then how would they grade you? See, the question is an ALI, an acute limb ischemia. They want to grade you on ALI. What is the point in you? Then they will say there is no vascular surgeon on call. You're 500 miles away. There's nobody else. You're in the middle of Scotland, some island in Scotland. You know, things like that would come.
So we can state we can do a statement that I will call a vascular surgeon, but I know that this is a problem of acute limb ischemia, and I know
something like that. Yeah. Something on those lines, which mean to say that you understand what it is. You haven't done the procedure, but it isn't that you don't know anything about it. That's what they want.
Makes sense.
So, is it okay to answer that this patient can be started on heparin, and we'll wait for the vascular consultant, or else I can ring the vascular consultant, ask him to give some suggestion on whether to mobilize the patient. Saqib was prompting me that the patient is on table, what incision you are going to make. I'm going to make an incision. The procedure,
the medical aspect of it is just resuscitation, isn't it? You're going to give fluids, oxygen, IV heparin, analgesia. So all these are like resuscitation. You have to mention that even before you call the surgeon. I mean, if you think ALI, I think that's the next.
I missed that, isn't it?
Yeah. I think you said heparin, but not the other ones, like oxygen.
Not the other one, yeah.
Yeah. So especially for this, you have to remember all those things, isn't it? Analgesia, fluids, heparin.
Yeah, make sure that all these things, blood investigation, lactate, and all these things is done. Yeah, okay. All right, good. Do anyone wants to do, or shall we wind off? I think how many?
Yeah, you said 1 hour actually, isn't it? I thought it's only 1 hour.
So Varun, you can give me the responsibility of making the scenarios. If I mean we are.
Saqib, I'm happy for anyone to make the scenario.
Yeah. So if you have just share a link for the meeting tomorrow by this time, 8 o'clock is fine. If Gohan is okay, then what I would do that I will make simple scenarios on emergency cases, general surgery cases, hernia cases, and then we can have a discussion.
Yeah, I've got a few things. Amar, where did you read all this duty of candor and all these things?
Duty of candor is basically we had a group actually. We had a nice group in which we used to practice these questions, and these questions were the ones that really came actually. So we were like 3 or 4 of us. We kept practicing before the exams last year, so kept on doing those, and we discussed these things, and and that's how we answered these questions. We had just notes about it.
So just include all these topics in the WhatsApp group.
No, so these topics are rare ones, but these are the topics that really put you off guard. You know, in the exam when you go, sometimes you get these topics as the first case. When you go for the exam, and then it ruins your day sometimes if you're not prepared. These topics either can be very well for you if you know something about it, or they can really put you down actually.
Actually, I'm completely not up to the point on all these topics because I don't know the UK protocols as well.
So, nothing wrong. That's
it's nothing wrong in the sense that it because see, you're going for 3 questions, isn't it? They're going to ask you 3 questions. So if it is the first thing that they ask you, it will definitely color the second and the third questions that they ask you. You know, the examiners. And if they give you a low mark for one, it will definitely reflect on the others. Though they say that it wouldn't reflect on the others, like the second and the third questions. If you are a human being, it will definitely reflect. You understand what I'm saying? Because though the college says one question does not affect the other question. You know what the examiners ask, but it definitely does, isn't it? You're a human being. I'm a human being. If you do well in one, it reflects on the other 2. So that's all I'm saying.
Can you give me a list of whatever, because I totally derailed all this things.
That's the reason I asked Amar to put something on the WhatsApp group to list of things.
These are all like nuisance questions which they can ask you, but they really ask you these questions actually, you know. And coming to Sorry.
Sorry, what I recall one as well. Just tell me, Amar, do they ask about the clinical governance as well? The 6 pillars of
Clinical governance,
Definitely.
JCIE, they ask you, because I did both. So when I went for, I don't know, you're applying for both JCIE and JCIE.
No, all the candidates are JCIE.
Yeah, JCIE, they ask you clinical governance, but it all comes in, orals, isn't it? Just your the next day orals. Clinical governance, like the 7 pillars that they ask you, or on audit and things like that. But this one, they can ask you as a thing in this question also.
Okay.
So, I mean, if now I think you'll be well prepared. It's just a question of you being aware of that they can ask questions like these, That's
Yeah.
it. Yeah. I don't think they
And
really...
can you suggest like any more things like that, like dealing with a difficult colleague? I heard from one of my colleagues, and like any more of this rare thing, because I need to read up something on this in order to like.
We'll get
Yeah,
Amar into a session at least half an hour.
I'll do something. Yeah, I'll get. I'll do one day before, because I don't think I
Please.
can come the week because I'm going for I'm on call. But you let me know which day you're free and I can free. I can do all these kinds of rare questions, something like that. Because
anytime this week.
Sure, because the easy ones everybody will do. The acute pancreatitis, everybody knows it's going to come, and everybody would prepare for it. So where is the the difficulty aspect in those questions? Because everybody knows acute pancreatitis will come in some way or the other in the exam. It's these small questions that really affect your mood through the exam. Like femoral hernia, everybody knows it's going to come for your exam in one way or the other. One type of hernia is going to come. One type of pancreatitis, something with pancreatitis is going to come.
Yeah.
So if this is also covered, I think you're covering all bases and it's going to be very easy for you.
Can we do this weekend? If are you available?
Sure. I'll let you know. I'll let Varun know, and I don't have your number. Sure. I think I have my number too, but I'll let Varun know.
Is that the WhatsApp group? You can have it.
Sure. We'll do one day.
We'll organize. Go ahead. I will try to liaise with Amar and we'll organize it. No problem.
Sure. Something like this. These tricky questions. There's another tricky question also, like on consent also. So we can do in consent also, because that's where they're asking you. Those are the difficult aspects of it. The exam is not about the easy ones, the rote memory ones. That's fine. Everybody will answer those questions. It's what will you do in these situations where you have to be very clear on what you think of, and that's what they're expecting also, isn't it? Yeah. We'll do one day. We'll do that. No worries.
Sure. Thank you.
No worries. Thank you so much for your time, and I'm sorry.
Thanks, Amar. We have to thank you a lot.
Thank you so much. I wish you all the best. But
thanks, Amar. Thanks for coming. Thanks for joining.
Thank you very much.
Good. Thanks, Sakib. Thanks.
Are we meeting tomorrow? Shall I make the scenarios?
I'm happy to do it.
Sure.
Just around 4 o'clock or 5 o'clock, please text me in the group that are we doing it or not, because I will know what I'm doing at around 8 o'clock. Sometimes I used to come and sleep.
You just need to share the link. The rest of the questions bit.
Sure. I'll share the link by around 4 o'clock once I start from the hospital.
Can we do by 7 or 7:30 if it's okay for you? Or
yeah, that's fine. Go ahead. Are you on nights?
No. Actually, one other person who's giving the exam with me wanted to discuss upper GI at 9 p.m. So I thought I'll finish this.
Ask him to come and join us by 9 p.m. You can discuss and we will also learn.
Sure.
Happy?
Okay.
Yes. Of course.
We will be happy as well. I think Sakib is colorectal.
Sure.
I'm going to be upper GI, so we can discuss as well.
Okay. So send me the link. I'll forward to him and I'll ask him to join in that.
Sure.
All right. Thank you. Thanks all. I'm going to wind it up.
Thank you very much.
So that tomorrow will be just hernia, emergency, and few critical care. I will make scenarios.
Yeah, Gohan will inform us about the teachers about the upper GIs, stomach and esophagus.
Sure.
Okay.